Right, welcome to another case at the Hammersmith Hospital. What we have is a gentleman who's 85 and several issues to discuss. Number one, coronary disease and aortic stenosis. Do one, do both, do neither, leave him to it. So we'll discuss that. The other thing is, okay, if we're going to use a TAVI technology, which one, given that we want to maintain coronary access? On the outside, biologically young 85, on the inside, severe coronary disease and severe aortic stenosis. So Neil, where have we got to so far?
So as we normally do, ultrasound guided bilateral access, we'll show the CT as part of the case discussion, and we can see that there's quite a lot of peripheral tortuosity. And if we have a look at the first angiogram, we felt on the CT that whilst both were tortuous, we probably thought the right on balance is probably better. And you can see the peripheral angiogram here following kind of common femoral access on the right. And if you go forward one, we've just taken a sort of RAO view, and you can really see that it's a bit of a corkscrew loop-the-loop. On the left side, and we'll see the next shot, please, you can see that there's, again, a pretty aggressive tortuosity here. I've opted to go with the right side on the basis that I think that that'll probably be easier to manage. The first J-wire didn't go up on its own, and we had to kind of coax it up. After a ProGlide, the first, if you go forward one, you can see that the wire kind of does get sort of caught up in that tortuosity, but just with a bit of time, we can, coax that up. So we've got two ProGlides on the right, femoral as per our usual practice. And I hope that with stiffer wires, that will straighten up. We talked about other options if we can't advance catheters, including buddy wires or even a sheathed device, and we'll talk about which device we chose and why. But there are lots of tips and tricks that we can use to try and straighten out peripheral vasculature. But I'm pretty confident we should be able to get some kit up. And in fact, because of that tortuosity, that might also guide which technology we choose.
Okay. Okay, great. So I suppose we have the choice of technologies in saying he has got some LVOT calcification, and so we could say maybe that means that Edwards valve may not be quite as good, although there is a paper which says it doesn't seem to make much difference. Then we have self-expanding technologies. We've got access to both the Abbott technology and the Medtronic technology. We have the FX Plus, which could give coronary access. We've managed to align it, but it's a bit more tricky to align, especially when there's twists all over the place. And so we've ended up thinking that probably the Abbott technology, the Navitor, will be the one that we use. Probably the most flexible down in the leg, and then hopefully with big cells to allow coronary access if we need to in the future. So while we're just getting the coronary angiogram pictures, obviously there's a left main stem stenosis, so we'll be a bit careful. And that's fine, okay. And can you do the RAO? So RAO caudal, sorry, RAO caudal. Okay, so eccentric distal left main stem bifurcation plaque, which we know about.
Straight
I've got to say, it doesn't look critical, does it?
So it's a sort of 1-1-1, isn't it? Probably
It
moderate
is.
to severe. But
okay, so I think we've got enough of those. Good. That's it. So play that one, and we can see that there's a haziness certainly next. And again, and the final one. Too. So we've seen the pictures, and I think we're going to agree, Neil, leave that alone, yes?
yeah,
Not easy to do,
no.
and we'll expend quite a lot of time and contrast when I think the valve is the main issue. There's a chap who thought of the idea, did lots of animal work, did benchtop work, and then the first human implant was by a French cardiologist. Oh, not bad. Okay. Okay, so that is a very reasonable overlap, isn't it? So those two views are good.
So 10,000 a heparin. Can I get another 2,000 at the top end, please?
Rod?
RAO, please. Thank you.
That's good. What's next?
So the tortuosity is going to be a challenge. I can feel it.
You can feel it.
Okay.
Now, I'd like a favor from you. Okay. Well, two favors. Number one, lie nice and still, which you are doing. Wonderful. And number two, at the end of this case, I'd like you not to have had a stroke. Okay. So if you could sort that out for me, that would be great. The circular wire.
Got it. So do you want to test your pacing now?
What's that? What? Oh, great. Okay, wonderful. Okay, good. You'll feel your heartbeat racing a bit now. Okay. Switch on to the hemodynamic screen. Hang on a second. So,
Oh,
Gabe, are
stop
you
there.
out there?
Stop, 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 stop. That works. Okay.
Yeah, fine.
Okay. That's fine.
Never mind. Carry on. Yeah.
Okay.
Oh, yeah. Problem is the. Okay, I suppose it's holding. So,
Well done.
little pushing. Little pushing. Can you feel that? Okay. So, that's just
Okay.
the skin.
Well done. Okay.
Okay.
Good.
So, up you go
Calm.
to the wire. So that was just to say we were in the, okay, now I'm holding the wire still and it's pushing up nicely. Okay, so you felt that, didn't you?
Well done.
Okay, so you're doing very well. So we've done most of the pushing. There may be a little bit more a bit later on. We'll give you a warning, okay? Flush syringe, please. Okay, so was that a bit uncomfortable? Is it still uncomfortable? No.
Yeah, the pins are all straight, aren't they? And there's no. Yeah. Okay. So
Yeah, that's good.
Yeah.
Okay, super. So let me give that back to you. You'll feel your heartbeat racing. Don't worry about that, okay?
Yeah. Yeah. And down. Pacing off. Grab the fluoro. Well. Okay. Bit of pushing in your leg.
Okay, try and hold still. Try and hold still. That's it. Try and hold still. Okay, let's go down to the leg. Let's go down to the leg. So we can just get through the skin. Leg. That's it. Okay. It's coming. It's coming. I'm wiggling. Probably further downwards. You want to angle it downwards?
Yeah.
Okay, so just angle more vertically. Yeah. That's it. Stop. Okay, so record that. We're wiggling the wire.
Well done. I know. I can understand that's a little bit uncomfortable.
Oh, well done. You've done the hard work. That's super. Okay, so let's stop there. So, and we'll rotate slightly. So what's the ideal position? We've got two markers there. Where do we want it? We'll have to rotate slightly to see whether we can even see them. So I can see there. That's two markers. Okay, fine. So let's see if I can. Hang on. No, there's definitely a kink. So can you bring it back? I saw it uncatch itself. So we'll have to rotate it, okay, because it's got bend on one side and not the other. Okay, stop. So it's just getting round. The trick there was to rotate it by 90 degrees because although it's very flexible, there is one plane it can't rotate in and the other plane it can. So we just rotated it to get it to help. Right. So that was the caudal, which is going to be the cusp overlap, which we're going to align in if we possibly can. Next one. And that was the other view. Okay, so we've got those in our head. If we ask for them, you know them. Okay, so let's go to the cusp overlap view. Yeah, okay, fine. So before we push all the way down, let me see if I can. Actually, that's coming
That's pretty
right.
good, isn't it?
Yeah, okay, so let's carry on. Yeah. Yeah, so that's actually pretty perfect. So acquire that. Okay, so we've got those well aligned. And so rotation will take it, and there's a lock, so it can't over expand. We probably don't need to pace, but let's check the height. So let's have a quick puff. So I'm going to start releasing. Neil's got the wire. I always like someone to hold the wire. That's slipping downwards, so that's why he's got it. And so we're going to realign. The pigtail hasn't really moved. Neil's adjusting. And so really where those markers are pretty good at the moment. So just before it fully expands, let's take a quick puff. Looking very good. And we don't want to be too low. We've got a pacemaker in already. So that's a good height. You agree, Neil?
Yeah. That's what I'm trying to land it there.
So you can see that the markers are no longer quite as good as they were. That's a problem with alignment. That's a great position. So I'll go to the rumble. Pressure is still good, as you can see. And we can still retrieve until we've broken the lock. So we haven't got to the lock yet. And there was absolutely no pressure change, but it is very eccentric and off-center. So we need to check those valves. So let's check in this view first. Yep. Which looks okay. Let's go to the other view. Yeah. So let's go to the other view. And this is often the way, isn't it? We've got the height probably okay for this case, but who knows about the alignment? So we've got the standard 3-cuss view,
More
which is
caudal.
looking, can you go slightly more caudal? Oh, the height looks good on that as well. So I'm pretty comfortable with that. Okay, so there's a button to press. Once we press the button, then we're able to release. Okay, so we'll go nice and slowly so that we can release the valve, and we've got our eye in, and now we are beyond the point of no return. Okay, so we're not pushing forwards, we're not pulling. Neil's on absolute neutral. And so we are actually looking pretty decent. And nice and slow. Let the tension come out of the system, which it did. I saw the bottom of the valve did not move one iota, but we still got one attached. That's probably all released now.
Can we get the other view just to see if you got concentric expansion?
Oh, actually, I think that's a perfect result.
I mean, I think the alignment's bang on, isn't it? What do you think, Kat?
I think it's very good. Okay, so go back to the other view. It's going to be easier to pull this out. It's not as extreme an angle. It's not in our face. Right, good stuff. So Neil's now going to pull the circular wire back a bit to try and lift up the nose cone, which he has done, to try and make sure we don't pull this valve out. And the nose cone is slowly milking back while we keep an eye on the bottom of the valve, which hasn't moved. And we'll take it back into the descending aorta, and then we will resheath. Okay, so resheathing. Okay, we're going to pull this, and Neil's got the wire. Actually, Neil, better if you hold that, and I'll do this. Okay, so ready to go?
Yep.
Okay, so we are able to pull back perfectly easily. That's good. And so now the system will come out. Is the 14 French sheath ready to go? And we're going to take everything out and put the new sheath in. You're doing ever so well.
I've got the leg down the wire. Yep.
So I'll take the wet.
Bit of pressing on your leg, sir.
That's good. That's a lot easier, isn't it? That's good. Okay, well done. Okay, so as we finish the case, I must say, Neil, I don't know the answer because you and I trained together. So would you like to do hemodynamics at the end of this case?
Always.
Always. Now, there are centres that are far too busy to do that, but we're planning to do 5 TAVI today and do the hemodynamics. And whenever I go and go to those people that don't do the hemodynamics, I say, how busy are you that you don't want to check your result at the end, not just on the fluoroscopy, but on the hemodynamics? As we've often discovered that the hemo is not quite right, and therefore what we want to do is to just optimize the valve a bit further, look at the AR index. So we can't do that if we don't have hemo. So
we're just going to re-zero both, yeah? So
still very fixated on hemo.
So
okay, and we're going to zero, and then we're going to activate the pressure. Look, number one, there's no gradient, which is absolutely brilliant. Number two, there's a dichrotic notch. And what we're looking at is the gap between the aortic diastolic pressure, which is just over 40. So the EDP is what? 9. Okay. So gently does it, and we're not out the woods until that wire is free as well and completely released, and we're screening all the way. Perfect. Okay, so oh, that's much more like it. Okay, so I think we've got a good position on the annulus and nice and high. So let's very carefully remove this catheter under screening because we don't want that valve moving along. The valve looks more expanded and the dots look further apart. We'll wait a couple of minutes and then just do one more contrast injection, okay, just to be absolutely sure. I can't see any color at all. And he had AR before. Yep. So I can get my 2D fit. There we are. Okay. Acquire. Yeah, and put the color on.
That's good.
Also good. Okay, super. Okay, let's take a picture. Yeah, it's definitely higher.
A little bit, yeah.
Okay, so it's definitely higher. So let's take this out slowly. So that's not bad because what we want is the left coronary coming out in between two of the posts, which it seems to. That's fine. Okay, super. So we'll just slowly extract this. Protamine in, please. Don't pull the wire out. Okay, yeah, that's looking pretty good already.
Not pressing at all. Yeah,
Yeah, it's
very
good.
good. That's great.
Okay, you're not pressing? Okay, I'm going to tie.
Do you want to take the wire out?
Okay, super. So JY, please.
Yeah.
Just got to take it right.
That's
There
it.
we are. Okay.
Nice.
Teased it round. Okay. Okay, so let's catch the bends as well.
That's
it. Okay, picture. Yeah, I'm very happy with that. We have seen a great result from a Navitor aligned fully with the commissures. I think the valve did move up slightly after deployment. Even though we hadn't tugged it with a pigtail or anything else, it just moved slightly. But it's in position. The calcium score is over 3,000. I'm sure it's fine. There's no aortic regurgitation. He's already